She's 65. She's a nulliparous woman. She told me that when she was...
Just a second. We want it darker here in the front so that we get better darkness on the screen. But you can have the lights up for the audience so they can write if they want to. So please, Antonia, go ahead.
Okay. So she told me that when she was 27, she underwent amenorrhea. She doesn't know the reason. So she used the hormonal therapy for 7 years, something like that. In 2007, she had breast cancer. She underwent surgery and tamoxifen therapy for 4 years. She was planned to take it for 5 years, of course, but after 4 years, she had bleeding, abnormal bleeding, and she told me that she went to the doctor and she underwent cystoscopy. I asked her several times, wasn't it hysteroscopy? But she knows what hysteroscopy is. She told me cystoscopy. She had antibiotics because of something phlogistic situation, and that's it. So I asked her, what about bleeding in the past 2 years? And she told me only spotting, sometimes spotting, and that's it. Last week, she went for a routine scan, she told me. Routine scan, and the physician found an ovarian mass. So she is here to check this ovarian mass. Shall we start?
Yes, please.
Okay. I would start transvaginally. So, can you see me?
Yes, I can.
Okay, my probe now is positioned at the entry. This is the bladder. Oh, I'm sorry, I put my bladder on my right, and I know that most of you use the other side. Okay, this is anorectal canal, urethra, bladder. I entered the vagina. Now, here we are at the cervix, so we can recognize the anterior part of the cervix, the posterior part of the cervix, the canal. Here I can see something, so I increase the depth, or can reduce a little bit, and there is something inside the canal. This is the level, do you agree, Elizabeth?
Of
the level of the, I would say, the internal uterine os for several reasons. Because it corresponds to the arrival of the uterine arteries from one side to the other. And usually we have these hyperechoic spots. It's an embryonic, something from the embryology. Okay, from the canal, I go up and I can see the corpus of the uterus. It appears enlarged. I reduce a little bit the gains. And I can see this mass inside, inhomogeneous ecostructure. So, to me, there is a problem here. So I can recognize a small amount of fluid here. But as you can see, there is something wrong here. Okay, what I do, I turn my probe. I see again the problem over there. I can scroll up and down. So now I increase a little bit our gain. Let's start from the cervix again. This is a transverse section of the gain. And I want to show you my idea, because it has to be confirmed, my idea about the paracervical region. This is the stroma of the cervix. Can you see here this hyperechoic tissue?
Yes.
Starting from the retrocervical area. Sometimes they're not symmetrical. Here you have the same tissue, thickened. And when there is a neoplastic lesion inside the cervix, I'm looking for some spicula here infiltrating the paracervical tissue. Okay, Elizabeth? May I go on?
Yes, of
Okay,
course.
this is
I'm
the
just
canal.
listening to you. Yes.
Sorry?
Yeah, I'm just listening to you. You may go on.
Okay. Here I can notice some hypoechoic tissue, and here. So, in conclusion, now I have found that this heterogeneous lesion, and I have to check several things. First of all, shall measure it. So, yes, Floriana is suggested to put on color, but first I would like to take some measurements. It's difficult, yes, to say here when it starts, but perhaps if you want to take some longitudinal, I would say from here until at least here, and from here until here, more or less. So we are talking about 6 centimeters. Then a torn map, and the transverse diameter is around 4. Now I can check, of course, at color, but I have to check the PRF. The PRF is correct. I could reduce it to 0.3, but I think it's sufficient. So, and the idea is that this tissue is growing in the posterior wall.
Mm. How would you describe the vessel pattern, Antonia?
According to Elizabeth Epstein, it's scattered and with a very high color score. Do you agree? Multiple scatter, multiple global.
Yeah, I would actually call them multiple global because the vessels are entering both from the front wall and the back wall,
Yeah.
but predominantly, I think, from the back wall.
Okay. Now, so we checked the vascularization. Now we have to say, we have to check the myometrial infiltration. So if you look in this transverse section, I don't think that here we have myometrial infiltration. So to me, it's growing from this side, and I think that here the infiltration is more than 50%. What do you think?
I agree with you.
I agree?
Yeah.
And we usually measure the minimum free myometrium, so that is around 4 millimeters. Subjectively speaking, in my experience, when it's less than 4 millimeters, but it depends on several variables, it means more than 50%. But now another critical point is there infiltration of the cervical stroma? Why it's typical issue, critical issue? It's a critical issue because of we have to plan surgery. So radical or not radical? Now, I have some problem here because here it seems to be only endocanal. But when I move here, I am uncertain about this area. What do you think?
Yeah, I think it looks a bit suspicious, actually.
But you know, to my eyes, it could be I don't know the English for that, sorry. Some tissue inside. It seems to be a gland, okay, but with some connection here. Tumor and this one.
Could you put on some color
yes,
in
you're
the
right.
lower? Yeah.
You're right. We can try to obtain the maximum, so I try to reduce the box. Can you see there are vessels around, but not inside. So what can we say? That for sure there is a tissue in the canal, and we are uncertain about that, but it's quite suspicious. Can you see here? Okay.
But I mean, if there is signs of deep myometrial invasion, there is, I mean, this is a high-risk patient, irrespective of whether there is cervical invasion as well. So
you're right, but it's a matter of surgery.
Yeah.
You know, because you should, you should perform a more
radical surgery. Yeah.
So let's move on to the adnexal regions. So let's start on the left side, and here. Can you see there?
Yes.
I have to do something to discover the situation. Now, I reduce at maximum. I want to go down. This is at the maximum, but Another tool I can use is to put on harmonics, or to remove harmonic, just to check the situation. Okay, can you see here on the left region, we have this lesion. I scroll from one side to the contralateral side, and there are some anechoic area. The surface is quite smooth. We can check first of all, I call it solid according to the IOTA classification because the solid component is greater than 80%. We are talking about an ovarian lesion of 13 centimeters. Now I want to check the color. So this is the box power. I started with a very large box. PRF is correct. So it's vascularized, but not so much. Now I can increase a little bit the gain. And if I move my probe to my eyes, I would like to make some more comments, but perhaps after that. At grayscale, it appears as a secondary lesion. Do you agree, Elizabeth?
Yes.
And we described in the past a typical vascularization that is a lead vessel. It means a main vessel penetrating into the lesion with a tree-shaped aspect. So now I cannot show you clearly this lead vessel, what I mean for lead vessel. So it's a solid, there is vascularization, not so much perhaps because of necrosis there. Let's move on the contralateral side. So I turn my probe. Okay. I increase the depth. Can you see here? This is the right adnexal structure. Do you want? Okay, could be better. Thank you. Is it better to your eyes? We can reduce also the angle of view because I think that it's quite interesting to pay attention to this region. Okay, so we can measure. Elizabeth, can you check the time because I have no idea.
You have some time left. You have actually about 5 minutes left.
5 minutes.
Yeah?
So this is the ovary. Okay, 35 millimeters. But I have another idea also, that there could be an involvement of both the ovary and perhaps also the tube. But anyhow, it's abnormal.
Why do you suggest the tube, Antonia? Tell us.
Yes, I'll tell you later. Sorry, 1 second, just to show you the color. It's a little bit too much.
Reduce the gain.
Okay. Can you see there? Usually, we can recognize clearly that it's within the ovary. Let me see. Can you see this structure? It could be an involvement, just an idea. I cannot be sure, of course. I mean, the ovary involved in the secondary process, of course, and this could be the tube. But it's only, can you see? It's a sort of a sausage structure, something like that. The ovary, and can you see here?
Yes.
Do you agree?
Yeah, it could be so.
Could be, who knows. So, very well vascularized. And so, to me, it's a bilateral lesions, solid lesion. We have to check the presence of fluid. So let's look in the pouch of Douglas, only small amount of fluid. And now we have to see whether there is something in the peritoneum. So let's start from the anterior. This is the bladder. We can check in the vesico-uterine pouch, and I have to put this one not low, no, I have to go up to that region. Okay, I want to reduce it. Okay, I cannot see any sign of peritoneal disease. Now let's go in the pouch of Douglas. Was it clear how I explain, the paracervical tissue, or are there some questions about that?
Do we have some questions regarding the paracervical tissue? It's actually the whitish tissue that you can see, the hyperechoic tissue surrounding the cervix, which is more hypoechoic.
Here, there is only a small amount of fluid. I cannot see any carcinomatosis and so on. So this is the rectum. We can start from the beginning, and we can follow it. Okay.
Antonia, can you tell the audience what you are looking for? What are the signs of carcinomatosis? What are you searching for?
Okay, I am looking for some, carcinomatosis usually appear as hyperechoic, isoechoic nodules located on the peritoneal surface, or I'm looking for some lymph nodes, some nodules. Can you recognize the rectum here? Okay, usually we have endometriotic pain. Sorry. I don't want to, I cannot push too much, sorry, she was complaining. Usually, this is the ventral wall of the rectum, and endometriotic nodules are located here. Do you agree?
Yes, I agree.
When we have a neoplastic lesion, we have to look also behind in the mesorectum, so between the rectum and the bone, the sacrum. So I'm looking for something inside the peritoneum, but also something around the rectum. So I would stop here, and just if I have 2-3 minutes.
Yeah, you have like 1.5 minutes.
Okay, we have
but we can say 2.
Just to prepare the patient.
Yeah.
And to change the probe. Slowly. Be careful. Unfortunately, she's not so slim, so I cannot show you. May I say that, my ladies? Yes, I can. Okay, so I can show you what I can. And we know that these problems are related to the situation. Okay, let's start. We can. How kilograms is your weight?
I'm 95. I'm 93.
Around 100. Okay, here I am with my transabdominal probe. So usually, I know that in the audience there are some radiologists, so sorry because I'm not a radiologist, so I can just give you as I do routinely. Can you take a breath? Okay. Sorry, let's go back. This is, of course, the right kidney, and this is the Morrison pouch. So usually, if we have a fluid there, okay, it's ascites. Here we can check there is no fluid. Then I move on looking at the liver. Okay, out. Can you take again? So usually I start from the left. I try to check slowly out, okay, the capsula. And because when there is ascites, of course, it's easier. We look for some carcinomatosis there. Let's move. And I try to cover the whole liver. Okay, out. Let's move to the left kidney again. So, what about the spleen? We can check the spleen, perhaps there is a accessory, but nothing particular. Out again. So I'm looking again about the diaphragm, the surface, and the parenchyma. Out. No problem with the left kidney. Can you see there is no hydronephrosis? Now, I would like to conclude with the omentum. So this is the abdomen. I start by increasing the depth of my probe to adjust the focus. This is the wall, okay? And I look for a tissue. Okay, yes, thank you. Because I want to show you. Okay, this is the muscle, and here we are within the peritoneum. So to me, this is the omentum that doesn't appear too thickened here, but we have to check laterally and craniocaudally. So it's a little bit thickened, but I don't recognize nodules.
Yeah.
Is it positive to your eyes, Elizabeth?
Well, it's a bit difficult to say, but I think it looks a little bit suspicious, but it can also be because of the patient not being completely slim. So,
Yeah.
But I would little bit suspicious in my eyes.
Yes, and following Daniela Fischerova's teaching, we are trying to be careful to separate to assess, the omentus minus. This is the liver, this is the stomach. So we pay attention here. Then we go down, and this is the column, the transversus column. So we have to differentiate if we see some nodules above or down to separate, the supramesocolon or inframesocolon omentum. This is the hepatic hilum. So again, we check here. In this patient, it's not so easy to check the. Can you see the part of the pancreas, the splenic vein? We follow the splenic vein to the enter of the liver, just to check the hepatic hilum. Another criteria, important criterion to predict suboptimal cytoreduction is to look for suprarenal lymph nodes. So here it's really difficult for me to show you, but at this level, there is the superior mesenteric artery and the celiac trunk. So if we have some nodules above this region, this means an objective criteria of suboptimal cytoreduction. But sorry, but better than this, I cannot show you. Okay.
Antonio, I think we should try to move on, not to get too late.
Okay, it's okay?
Thank you for
so
your
much.
brilliant scanning. It was really fascinating. Thanks a lot.